Hello, and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. We encourage you to ask questions and share ideas to help the community learn and grow. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. You can also sign up for a free trial of our premium membership to get access to hundreds of case-based microlearning courses across all key radiology subspecialties. Today, we are honored to welcome Dr. Susie Bash for a lecture on critical updates in the dynamic landscape of Alzheimer's disease and dementia imaging. Dr. Bash is a neuroradiologist and medical director at RadNet. Prior to this, she was on the faculty at UCLA as an assistant professor of neuroradiology after completing a 2-year neuroradiology fellowship and residency, also at UCLA. Dr. Bash's passion and interest lie in artificial intelligence applications in advanced neuroimaging, which add patient-centric value and quality. She's a recurring guest on TV, radio, and podcasts and is actively involved in AI clinical trials, peer-reviewed publications, and AI-related educational talks and webinars. Dr. Bash serves on the medical advisory board of several AI companies and also serves on the editorial board in the AI section for Applied Radiology and is a frequent contributing author to this journal. At the end of the lecture, please join Dr. Bash in a Q&A session where she will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we're ready to begin today's lecture. Dr. Bash, please take it from here.
Hi, my name is Susie Bash. I'm a neuroradiologist at RadNet. Thank you so much for joining us. Today, we're going to talk about critical updates in the dynamic landscape of Alzheimer's disease and dementia imaging. These are some disclosures. So first, we'll focus on sort of an introduction to dementia. Then we'll talk about dementia imaging, then disease-modifying therapy and regulatory updates. And then we'll move into ARIA, which stands for amyloid-related imaging abnormalities. And we'll actually do some ARIA training with clinical cases so that after this webinar, you'll feel comfortable reading ARIA cases. And then we'll talk a little bit about the future of dementia and then get into some dementia clinical cases. So there are a lot of different kinds of dementia, Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementia, logopenic progressive aphasia, traumatic brain injury, cerebral amyloid angiopathy, and CAA-related inflammation, as well as normal pressure hydrocephalus. We won't have time to talk about all these today, but we're going to primarily focus on Alzheimer's disease. And the reason we talk so much about Alzheimer's disease is it makes up the majority of the causes of dementia, with over 60% by autopsy. So there are 6.7 million Americans that are suffering from Alzheimer's disease. It's a big population issue, costing our nation $355 billion in 2021, and that will rise into the trillions very shortly. 1 in 3 seniors will die of dementia, so that kills even more than breast cancer and prostate cancer combined. Death from heart disease is down 7% since the year 2000, but death from Alzheimer's disease is up 145%. And this is something that really progresses as you get older, so it doubles in frequency every 5 years after the age of 60. Now, Alzheimer's disease has 2 major hallmarks: beta amyloid plaque, which is extracellular and can be directly imaged with amyloid PET, and neurofibrillary tangles, which is intracellular tau, most notably in the hippocampi, and that can be imaged with tau PET. Now, amyloid PET study can be positive at the preclinical stage of Alzheimer's disease, in fact, up to 20 years before the patient's symptomatic. Amyloid plaque by deposition in disease, you'll tend to see a lot of it with Alzheimer's disease. You can see some with dementia with Lewy bodies, but you shouldn't expect to see any amyloid deposition in frontotemporal dementia. This is an Alzheimer's cell here with plaque burden and neurofibrillary tangles compared to a healthy looking cell. This is a positive amyloid PET here, and this is a positive tau PET. Beta amyloid 140 and 142 peptides are produced from amyloid precursor protein. The beta amyloid 42 is the main peptide associated with Alzheimer's disease, and beta amyloid 40 is the main peptide associated with cerebral amyloid angiopathy. These beta amyloid peptides are transported across the blood-brain barrier and then degraded by specific proteins and enzymes such as apolipoprotein E and MMPs. The accumulation of these amyloid fibrils in the walls of small to medium-sized arterial blood vessels and capillaries in the cortex really are thought to result from a disturbance of any of these time points, either from increased production, impaired transport, or impaired degradation of the beta amyloid peptides. So this aberrant pathway really helps explain cerebral amyloid angiopathy, which is known to cause spontaneous intracerebral hemorrhages, cognitive decline, and transient focal neurologic events, in addition to Alzheimer's disease. Now, we're now starting to realize the importance of the glymphatic system and the role it plays in the clearance of beta amyloid plaques and other toxins. So the glymphatic system denotes perivascular pathways whereby CSF enters the brain parenchyma via the paraarterial space and then mixes with interstitial fluid. This drives clearance of interstitial metabolic solutes and waste, such as beta amyloid plaque, which then exit the brain via the paravenous pathway to drain into the lymphatic system. Now, these astrocytic aquaporin 4 water channels in both the arteries and the veins play an important role in reducing the resistance of CSF to movement between the perivascular spaces and the interstitium. Now, unfortunately, as we age, this lymphatic convective drainage pathway and the clearance of waste products such as beta amyloid plaque will slow down. So reduced waste clearance has not just been associated with Alzheimer's disease, but also with traumatic brain injury, hemorrhage, hypertension, strokes, and microvascular ischemic disease. Interestingly, when we sleep, these interstitial spaces increase in size, allowing more effective clearance of the beta amyloid plaque. So good sleep patterns actually are thought to play a protective role in Alzheimer's disease. Tau is a protein that helps form and strengthen microtubules, which transport nutrients along the axon. Now, in the diseased brain, there's an imbalance of protein kinases and phosphatases, which cause tau to become abnormally hyperphosphorylated, resulting in the disassembly of these microtubules. And this impairs cellular signaling. So free tau molecules then aggregate into insoluble paired helical filaments and straight filaments as well, which accumulate in cells as neurofibrillary tangles in Alzheimer's disease and other tauopathies. So tauopathies would include Alzheimer's disease, behavioral variant frontotemporal dementia, chronic traumatic encephalopathy, Downs, progressive supranuclear palsy, and corticobasilar degeneration. There are two main types of Alzheimer's disease, early onset, which is familiar, that's less than 5%, much more rare, and late onset, which is sporadic, and that's 95%. Non-modifiable risk factors include age, gender, so it's more common in women, probably because women live longer, and also genetics. ApoE4 is the most common genetic risk factor associated with Alzheimer's disease. Now, modifiable risk factors include hypertension, diabetes, smoking, excessive alcohol use, obesity, poor diet and poor exercise, lack of cognitive engagement and social isolation, depression, traumatic brain injury, and then, as we mentioned before, sleep deprivation due to the glymphatic system. So apolipoproteins play a role in lipid and cholesterol homeostasis in the blood. There are three ApoE gene alleles, E2, E3, and E4, of which E3 is by far the most common. Greater than 50% of the population has this. ApoE4, however, is the strongest genetic risk factor for Alzheimer's disease because it's involved in impaired clearance of that beta amyloid plaque. So 25% of the population carries one ApoE4 allele, and so they're called heterozygous, and they carry a 3 times risk of Alzheimer's disease. But 2 to 3% of the population carries 2 ApoE4 alleles, so they're homozygous and have a 12 times risk of developing Alzheimer's disease. Now, ApoE4 is a risk factor not just for Alzheimer's, but also for cerebral amyloid angiopathy, CAA-related inflammation, dementia with Lewy body, tauopathy, microvascular ischemic disease, and vascular dementia, multiple sclerosis, poor outcome following traumatic brain injury, and also ARIA. Now, when it comes to dementia imaging, typically a patient will present with memory loss and undergo cognitive testing, often by the neurologist, and then an MRI is typically ordered in part to rule out other pathology that could be causing the memory loss. So, for example, posterior cerebral artery strokes can often infarct the hippocampi and result in some memory loss. So can heavy burdens of microvascular ischemic disease. Sometimes quantitative volumetric imaging is done. We actually do this pretty routinely in my clinical practice. We've been doing it for about 17 years now. We find this very helpful in the evaluation of dementia. And then if there remains clinical ambiguity, sometimes a PET study is ordered. FDG PET is by far the most common PET study ordered, and this is reimbursable by CMS. Amyloid PET is hopefully right on the brink of being reimbursed right now, which we'll talk about in a minute. And then tau PET, which is so far not reimbursable, but can be used in the evaluation of dementia. This is a positive FDG PET. This is the PET MR fusion, and these are both PET CT fusion images. And you see cortical hypometabolism in the bilateral temporal lobes here. And this patient had Alzheimer's disease. This was statistically significant when I ran it through the MIM neuroanalysis software. Now, this is amyloid PET. Just for example here, this is a negative amyloid where you see a tree and branch type pattern and no binding of the amyloid tracer to the cortex, as opposed to a positive PET where we have diffuse binding of the tracer throughout the cortex. This is color fusion right here. Quantitative volumetric imaging identifies and labels anatomic structures in the brain and then quantifies the volume of those brain structures and compares that to an age and gender matched normative database. And this provides volumetric tracking to assess for rate of change over time. There are different companies that perform quantitative volumetric imaging. That was one. Here is another. This is another one here and another here. And then finally, this is one that's in development. And there's different reports that these companies produce but basically they track different pertinent areas of the brain and compare that to a large normative database. Anything in the pink zone here would be more than 2 standard deviations outside of the mean. So you get an idea of what is important and statistically significant for that patient's age. This is a triage brain atrophy report, which is again broken down by areas of the brain. This is another report from a different company that's also tracking the volumes over time and comparing to a normative database. And this is what another report looks like here. Now, when it comes to PET imaging, again, we tend to use amyloid, tau can be used, and FDG PET. And these are what these studies look like in the normal scenario. And here's abnormal. This is a positive amyloid PET, a positive tau PET, and this is a positive FDG PET. This patient happens to have Alzheimer's disease. Now, the FDG PET patterns would look different across different diseases. Alzheimer's would be temporal parietal, and posterior cingulate gyrus frontotemporal would, as it sounds, tend to be frontal lobes and temporal lobes. Dementia with Lewy bodies can look a lot like Alzheimer's disease or sort of a diffuse pattern, but will often involve the occipital lobes as well. Now, tau PET, unlike amyloid PET, tau PET accurately predicts the location of future atrophy. So here is an amyloid PET where we have diffuse binding, but this is a tau PET where tau accumulates in the areas that have atrophy first. So so this is tau here and this is atrophy. So tau is actually a better predictor of the timing of imminent cognitive decline. Now, I'd like to talk about these important regulatory updates. This is a very exciting time for dementia. Following the FDA's decision on July 6, 2023, to grant traditional approval of Leqembi, the generic name is lecanemab, CMS then immediately affirmed that they will cover this medication broadly. So this is a very pivotal step that really is allowing a means for drug access to the millions of Americans that are suffering from Alzheimer's disease. And the only criteria for CMS coverage is you have to have Medicare, you have to have mild cognitive impairment or mild Alzheimer's disease, which must be documented as evidence of amyloid plaque. And then you also have to join a registry, which your neurologist will help take care of for you. It's on the CMS website, and it's a very simple registry for your neurologist to sign you up in. Individuals with original Medicare will pay the standard 20% coinsurance of Medicare-approved amount of Leqembi once they meet their Part B deductible, but Medicare will cover the other 80%. And actually, the largest health system in the United States, the VA, started covering this drug even before CMS. CMS was waiting for the FDA traditional approval before they decided to make the decision to cover. So that is very exciting. Now, there are different disease-modifying drugs that you have heard about so far. Aduhelm is really really a historical at this point because donanemab and lecanemab have really outperformed Aduhelm, but these are all IgG monoclonal antibodies. Aduhelm received accelerated approval in June 2021. Donanemab has not yet achieved approval yet, and lecanemab has received accelerated in January 2023. Aducanumab never received traditional FDA approval. Donanemab hasn't yet, but will file soon for this. And lecanemab received this just on July 6, 2023. So this is the first disease-modifying drug to have traditional approval. Now, all three of these drugs did a great job at their secondary endpoints, which is to clear beta amyloid plaque from the brain. But when it comes to the primary endpoint, which is slowing the rate of cognitive decline, Aduhelm did not do as well. So only in one trial, they had 23% improvement, but not in the other trial. Donanemab actually had 35% slowing in cognitive decline. Their results of their trial were just recently released in July 2023. And lecanemab had 27% slowing of cognitive decline. Now, the price tag for lecanemab is big at $26.5K, but you have to realize, also that this is a lethal disease, and to be able to give time back to our loved ones by slowing their rate of cognitive decline is a big deal. And again, CMS is now covering, as is the VA, and then private insurers tend to follow. So in the Clarity AD phase 3 trial, which was published in the New England Journal of Medicine on January 5th, 2023, lecanemab met the primary efficacy endpoint by slowing the rate of cognitive decline by 27% over an 18-month period, based on the clinical dementia rating sum of boxes. Now, in the Trailblazer-ALZ 2 phase 3 trial, which was published in JAMA on July 17, 2023, so just published, donanemab met the primary efficacy endpoint by slowing the rate of cognitive decline by 35% at 18 months. Additionally, nearly half, so 47% of the donanemab participants had no disease progression at 1 year with the CDR-SB rating scale. So that is a really big deal. Patients with less advanced disease, so patients that had lower medium tau burden, outperformed those with more advanced disease that had higher tau burden. And that is just confirming that the earlier the treatment is initiated, the higher the clinical benefit. Which is why the labels are suggesting this at the early stages of disease. So again, it's important to note lecanemab is the only one that's approved by traditional approval to treat this early Alzheimer's disease, and approximately 1.5 million Americans will be candidate for on-label therapy with lecanemab. So again, 6.7 million Americans have it, but when you just look at the early stage disease, we're probably talking about 1.5 million. Now, numerous other trials are also ongoing, including disease prevention trials, such as the dominantly inherited Alzheimer's network trials. And then there are several trials that include pharmacologic targeting and monitoring of other disease biomarkers for Alzheimer's, such as neurofibrillary tangles, which can be imaged again with tau PET. Now, the National Institute of Aging is currently funding more than 450 active clinical dementia trials. So there is a lot of activity in this space. This is looking at the primary endpoint for the Clarity trial. And here you can see lecanemab here slowing the rate of cognitive decline compared to the placebo. And then if we look at the secondary endpoint, which is clearance of the beta amyloid plaque, there's just no comparison. Here's placebo here, no change, a slight increase in plaque. Whereas look at how well lecanemab is doing in dropping the amount of amyloid plaque in the brain. So again, here's placebo on an amyloid PET, looks the same a year later, but the treated limb is really doing a good job of clearing that plaque. Now, the efficacy of clearing the beta amyloid plaque is dose dependent. The higher you go up in dose, the better job it does. Here's 10 mg per kg, and this is the, you can see that much more plaque is cleared at the higher dose. But the problem is like most medications, there can be side effects. So with disease-modifying therapy in Alzheimer's disease, with using monoclonal antibodies, the side effect is ARIA. ARIA-E stands for edema or focal effusion that can develop. So here's edema that's developed, and here's a focal effusion. And ARIA-H, H stands for hemorrhage, represents microhemorrhages that can occur in the brain. So you see these tiny little dots on GRE, or superficial siderosis. Now, focal effusions with ARIA are thought to represent a leakage of proteinaceous fluid from the meningeal vessels. And the ARIA-E edema is thought to represent leakage of proteinaceous fluid into that parenchymal interstitial compartment. If we look here across the disease-modifying therapies, you can see that the incidence of ARIA is much higher with Aduhelm. With Leqembi, it's the lowest. It's 21% overall. You can see that the ARIA-E is about half of that for donanemab. And the symptomatic ARIA, which is the one that we really care about, again, much higher for Aduhelm. With donanemab, it's 6%, and then less than 3% for lecanemab, so about half that of donanemab. Symptoms of ARIA can be varied, but it's often could be headache, confusion, dizziness, nausea, vomiting, or visual disturbance. And the risk factors include that initial treatment period. So when you first go on treatment, at first 3 or 4 months, you're at higher risk for developing ARIA. Also, the higher doses are associated with an increased incidence of ARIA. And if you're an ApoE4 carrier, you have an increased incidence. And so the label, lecanemab label, actually recommends that you get tested for ApoE4 just so that you can go over your risk with your neurologist and have a decent idea of what your risk of developing ARIA is. So right now, patients are paying out of pocket for that genetic test, and maybe in the future that will be covered, but that's why not everyone is getting it, but it is useful if you do get it. Other risk factors for ARIA would be cerebral amyloid angiopathy, and then if you are on anticoagulation, you are also at a greater risk of bleeding. ARIA-E in ApoE4 carriers occurs in 5% of heterogeneous carriers and 50% of homozygous carriers. Again, why it's useful to get the test prior to starting medication. But again, the good news is that symptomatic ARIA, which is what we really care about, is in less than 3%. And the ARIA-E nearly always resolves within 1 year. In fact, typically within 4 months, but usually always within a year. So again, 97% are asymptomatic. Here's a look at ARIA-E temporal change over time. So this was the initial development of ARIA-E. It sort of got worse, and then it started getting better, and by 300 days had resolved. Here's another case. Here's the baseline MRI. This is post-dosing. The patient developed ARIA-E, but on the post-dosing follow-up, which is typically, the follow-ups are typically done at 1 month, it had completely resolved and the patient could resume treatment. Here's another patient. Here's their baseline. They developed ARIA-E post-dosing. It got a little worse at the 1 month stage, and then by the 2 months, it had gotten better. But this is the GRE here. You notice here at the post-dosing, they developed some ARIA-H, just 2 microhemorrhages, just very mild. That got a little worse over time and was even worse again at the second follow-up study. So let's talk about how you grade ARIA. There's mild, moderate, and severe, and there's specific criteria for this. So ARIA-E grading is all about the size. Pay close attention to this slide because we're going to go through some cases, and I'd like you to be able to choose what you think the grading is. So mild for ARIA-E is 5 centimeters and monofocal. Moderate is less than 5 centimeters and multifocal, or between 5 and 10 centimeters, and that can be either mono or multifocal. Then severe is greater than 10 centimeters, and again, can be mono or multifocal. So once you get into multifocal, you are by definition moderate or severe in degree. Now, ARIA-H, unlike ARIA-E, is all about the count. So it's not about the size, it's about the count. So microhemorrhages, if you have less than or equal to 4, you're considered mild ARIA-H. If you have between 5 and 9, you're moderate. And if you have more than 10 or equal to 10, you're severe. Now, superficial siderosis would be mild is 1 focal area, moderate is 2, and severe is greater than 2. So you need to follow along the sulci and see if it's all one area of involvement. Now let's talk about, or let's look at some clinical cases where we can go over grading. So what I'd like you to do is, as you're looking at this, think in your mind what you think the grade is. So here's baseline and here's post-dosing. We see one area here of ARIA-E development. It looks like it is less than 5 centimeters in size. So this is mild. It's monofocal and it's less than 5 centimeters. Here's another case. You have 3 areas of involvement post-dosing. So that would put you into the moderate category because it's multifocal. Here's a patient at baseline. And here's post-dosing. And you see here, there's extensive involvement. In fact, you might be wondering, did they have a big stroke, which is why DWI is a required sequence for ARIA screening. And no, this is not a stroke. This is just shine through artifact. So this is severe grading here. Here's another patient. Here's the baseline, and here's post-dosing. We see a little area here of a focal effusion and another little area here. So this is moderate because it's multifocal, and so we're in the moderate category. It can't be mild. Here's another patient here, and we see multiple focal effusion here on both sides of the brain. So this is going to be a severe ARIA-E case. And here is again baseline. Here's post-dosing. We have this area of focal involvement, and this is actually a mild case because it is only involving one area of the brain here, and it is less than 5 centimeters in size. Now, here's another case here where it's a little bit larger. It looks like it's probably just under 10 centimeters in size for focal effusion, so this is moderate in degree. Here is a baseline. Here's post-dosing on GRE, and we see some microhemorrhage here. And here's baseline on the flare, and here's post-dosing on the flare. This is mild for ARIA-H because there's less than 5 foci, and it's also mild for ARIA-E as well. Now, here's a GRE here, post-dosing. You see multiple little foci. If you count these are actually, I don't know if you can see it, but there's actually 5 little foci here. The number matters, and even though it's small, you have to count the individual little foci. Here's on flare where we see one area. So this would be moderate ARIA-H because we have 5 foci here, and mild for ARIA-E because we just have one small area. Here's another patient, baseline, and then the post-dosing GRE. We clearly have over 10 foci here. And on the baseline flare and then the post-flare, you see an extensive area involvement. So this is severe ARIA-H and severe ARIA-E. Here's another, this was actually post-dosing, and this is all on the same patient, multiple little foci of microhemorrhages, so that's severe ARIA-H. Here's another case here. This is the baseline. Here's post-dosing where we see superficial siderosis here. And then we have 2 foci of microhemorrhages. These are actually just vessels. That's not hemorrhage. And so how would you grade this? This is actually mild ARIA-H, which you might be surprised about, but it's because we have just one focal area of superficial siderosis. If you follow these down, these are all contiguous sulci, and we just have 2 little dots of microhemorrhage. So we're mild in category for microhemorrhage, and we're mild in category for superficial siderosis. So it doesn't upgrade our call. The call stays as mild. Here is the baseline. Here is post-dosing. We have superficial siderosis here and a second area of superficial siderosis. Again, it's important to make sure you know if you're in the sulcus or if you're in the brain parenchyma. This was judged to be in the sulcus, so it is moderate in degree because we have 2 areas of superficial siderosis. By the way, if this had been in the brain parenchyma, then we would have downgraded to a mild because if we would have called it 1 microhemorrhage and 1 area of superficial siderosis. But because this was judged to be in the small sulcus here, we are in the moderate category. Now, here's a baseline here, post-dosing 1 and 2 months. Again, you see it getting worse over time, but let's try to work on what we would call the grading. Here's the flare, here's the GRE. We see 2 foci here, some more foci here, and even more foci here. So this is severe ARIA-E at this stage here, and then resolved ARIA-E. For the ARIA-H, we're at mild for this one, severe for this one, and severe for this one. Now let's talk about ARIA-E mimics and pitfalls. This is very important to note. In this patient, this was actually a suboptimal protocol where we're really sort of getting some artifact here in the posterior occipital lobes. When this was, they actually weren't sure about this, had the patient repeat with optimal protocol parameters, and this went away. So that was just artifact. Now here, this patient was scanned initially at baseline on this vendor. They came back and were scanned on a different vendor, and now we see this. And the question is that development of ARIA-E? So what they actually did was put the patient back on this vendor scanner, and it looked just like this. So this was just artifact, and it was not development of ARIA-E. here is a patient, here's the baseline, and then you see here on the follow-up study, you see all this sort of focal flare hyperintensity, but it turned out the patient was on supplemental oxygen. They then took the patient off supplemental oxygen, repeated the study, and it looked exactly like the prior exam. So that was a fake out. It wasn't really an ARIA-E case. Now, this is a patient here. This is the baseline study. And then you see this very abnormal looking study, but they felt that the parameters might not have been optimal. There was poor CSF suppression. They actually repeated it with optimal parameters and it all went away. So this actually turned out to be a fake out, but that would be very hard to know that, but that's what it turned out to be in this case. Another thing to be aware of on is, metal artifacts. So this is the initial exam, and this exam, the patient had their hearing aid in. This is the GRE, and this is the flare. But on the flare, you can see there's all this abnormal signal intensity. But when you look at the GRE, you can clearly see its artifact from the hearing aid. And then this was a patient that this was their post-dosing. They did develop a small area of RAE, so mild RAE. And the question is, was this RAE as well? Which is why it's always mandatory that we do DWI when we're doing therapeutic imaging, because this turned out to be an acute infarct. Then, the dosing was originally suspended, but the RAE actually just went away, and that little focus stayed because that's just temporal evolution of the infarct. Now, when we talk about RAH, these are some pitfalls that you can see. This was the initial MRI. You see the small microhemorrhage. What happened to it? Did it go away? It turns out this is just differences in slice sampling and a different scanner, but that little focus is still there. But you can see how in reverse order, you may think that a microhemorrhage developed when it didn't. The other thing to be aware of is vessels. And so you have to track up and down and make sure you're not looking at a vessel. SWI imaging is much higher sensitivity for both vessels and bleeds. So it's a little bit harder, like you're finding where's Waldo in a sea of vessels, which is why SWI was not utilized for the trial and also why it is not recommended for therapeutic screening. That's why we use GRE and also to remain a consistent protocol. But this just turned out to be a vessel here. Now, when basal ganglion mineralization is symmetric and chunky like this, it's very easy to see. But when it's little punctate foci, it might be harder to tell. I would just assume that's mineralization, but again, it's something just to be aware of. And then also around the sinuses, you can get a dropout susceptibility artifact from the air. And so you don't want to overcall those as bleeds. And particularly with sometimes around the sinuses, mastoid air cells here, you can get little punctate foci, but those aren't bleeds there. And then the other thing to be aware of is this particular patient, you see this, what appears as susceptibility artifact bilaterally in the occipital lobes, but this was actually phase encoding artifact. So you just look for the march across the line in the phase encoding direction to differentiate true hemorrhage from just artifact. Now, when to suspend dose? So the criteria is different for ARIA-E and ARIA-H, but starting here with ARIA-E, the main thing to remember for ARIA-E is moderate and severe. Because whenever the degree of ARIA is moderate or severe, the dose must be suspended. And also, when the clinical symptoms are moderate or severe, the dose must be suspended. So anything in the moderate severe category, whether ARIA-E or symptoms, you're going to suspend the dose. If they just have mild symptoms, you don't need to suspend the dose. So this is very important for neuroradiologists and any radiologists that are reading this study to remember, because it's up to you to convey back to the referring neurologist what the degree of severity is and whether the dose must be suspended. So please do not forget to call the neurologist if you see an ARIA category that would require a suspension of dose. Now, this is ARIA-H here. If you're in the moderate or severe ARIA-H category, you're going to suspend the dose. But unlike with ARIA-E, any patients with ARIA-H that are symptomatic, you're going to suspend the dose. So all across here, if there's symptoms and you see any ARIA-H, again, this is over baseline. So let's say if they had on their baseline MRI 5 microhemorrhages, after their next imaging study, once they're getting dosed, if you see 5, you're good. But if you see anything, a therapeutic, microhemorrhages that has developed, that's when you start your ARIA grading. Now, what is the impact for imaging facilities? The primary impact is going to be increased MRI scan volume. So an MRI is required by label at baseline, and it should be recent. The old label said within 1 year, but now the new label has been changed to say recent. I don't consider recent a 1 year, obviously. So probably within a couple of months. In some institutions, they're going to sort of require it, but others, just if you've got it within a couple of months, then you're good to go. Then an MRI is required prior to the 5th dose, prior to the 7th dose, and prior to the 14th dose. These are all at the high dose categories, which is 10 mg per kg, administered by IV infusion every 2 weeks. So MRIs must be acquired prior to these. These are scheduled MRIs. The AUR guidelines also recommend an MRI prior to the 26th dose. That's at 52 weeks. So that's not on the lecanemab label, but it is a recommended schedule. So this is 5 MRIs here, and then plus additional MRIs, non-scheduled MRIs, whenever the patient develops a new neurologic symptoms. So if you assume maybe the patient might have 5 headaches a year, the neurologist is probably going to order an MRI each time, and probably on an urgent basis. So, if you assume about 10 scans per year, roughly, and let's say there's 1,500 treatment candidates in the United States, we're looking at 15,000 new MRIs a year impacting imaging facilities in the US alone throughout our country. So this is a very big number. Imaging facilities really need to be prepared for the increased number of MRIs that they're going to see. Now, another impact for imaging facilities would be consistency, and that is consistency in protocol, field strength, and ideally with vendor. The protocol is very important. So the required sequences as recommended by the ASNR, Alzheimer's ARIA study group, is a GRE, a FLAIR, and a DWI. I can tell you at our institution, we're just going to do a routine brain. Now, some people may be doing an SWI as part of their routine brain, and some neurologists may always require an SWI again because of the increased sensitivity. If that's the case, please do a GRE in addition to that, because when you're doing therapeutic screening, you need to do the count off the GRE. So in your dictation, you would report the number of microhemorrhages you see on both the GRE and the SWI, but just put a note in there that you're using the GRE for the ARIA grading. And then field strength, ideally really should be done on a 3T or 1.5T, and preferably maintain the same field strength between each visit. And then, ideally, if you can stick with the same vendor, that would be wonderful, but I know that that's not possible in a lot of cases. At our imaging enterprise, we're the largest outpatient freestanding imaging enterprise in the United States. We have 355 freestanding imaging centers that we read from. So we have a big, diverse fleet of scanners, so we can't always maintain the same vendor. Now, the other impact for imaging facilities would be an educational initiative for neuroradiologists, for training for ARIA. We're going to do ARIA training here in this webinar, but All's Imaging is a good website for additional information, and educational initiatives are also ongoing through the ASNR and through RSNA and through other educational webinars and things like that. Now, another impact is quantitative volumetric imaging. We're already, at least in my area, my clinical practice, my referrers order this for almost every dementia patient, but in other areas, it's not ordered as frequently, but this is a very useful AI tool. It can allow you to track the hippocampal volumes, and it can help with automated ARIA screening report, and was used in some of the trials. The other implication for imaging facilities would be the beta amyloid confirmation, which is required prior to treatment. It can be done through LP, which is covered right now. But again, amyloid PET would be a preferable way for patients to be screened for a beta amyloid confirmation. And, we're hoping to see that will be covered in the near future. And then Precivity AD, and also Quest has a new blood test as well. These are both blood tests. At this point, there's still some variability in the reliability there, and also no coverage as of yet for blood testing. Now, let's talk about ARIA reporting. So ARIA screening and follow-up can be reported manually. The neuroradiologists are, again, very important because it impacts the therapeutic decisions. It's in terms of the interest level for ARIA and Alzheimer's, it's very interesting because the ASNR, American Society of Neuroradiology, has an ARIA study group. There's about 1,000 neuroradiologists that come a year. There's actually 2,700 that are members of the ASNR, but about 1,000 make it to the meeting every year. And, they thought that there might be a small number who would sign up for the study group. Well, it turned out 800 neuroradiologists signed up for the study group. And then we sent out a poll to all 2,700 neuroradiologists that are members of ASNR. And of the responding polled neuroradiologists, it turned out that 63% of them were interested in using an automated proprietary computer audit detection, screening software, AI software for ARIA detection, longitudinal follow-up, and automated reporting. So we will talk about that and look at that. Now, automated ARIA reports are in active development right now from some of the major vendors and pending FDA approval. So this is kind of what it looks like, this automated segmentation for quantitative MRI. This is the white matter overlay, which would you use for ARIA-E screening on the FLAIR sequence, and the other input sequence would be GRE, where you'll see automated detection of the foci of microhemorrhage. So this is the GRE beforehand. You see these little foci of microhemorrhage, and they can be very small. And I'm not sure if you can appreciate this, but there's actually 2 right here. And then there's a few more along here, 1 here and 1 here. And this is what it looks like after the automated detection is applied. Here's an ARIA-E case, automated detection through quantitative MRI. Again, ARIA-E and automated detection. Here's an ARIA-E with focal effusion case that is color-coded after it goes through the QMI software. This was originally. So again, it's very useful for detection of ARIA-E and ARIA-H. There are different screening reports that can be generated. This happens to be one from one company where it will, for ARIA-E, it will give you the lesion burden and the count, what's new, what's enlarging, what's shrinking over time for ARIA-E, and for ARIA-H, again, the count. For ARIA-H, the count is mandatory. It's so it's very important here. We'll do the same thing for superficial siderosis and compare dynamically since the prior study. So here's sort of a summary report here for ARIA-E. Lesion 1, it's giving the diameter and size because this is what's required for the grading system. So you get the diameter for all 4 of these lesions, and you get the change from the prior study. It tells you where it is, right frontal lobe. And then it gives you a severity score for ARIA-E. And this is based on this criteria that we talked about before for mild, moderate, and severe. Here's our sample ARIA-H report that is in development. And again, counting the current microhemorrhages as well as the baseline, and you can get the change in the number. So baseline had 1, and then there was 9 new ones at the follow-up imaging. It will tell you where they are in the brain. And again, we'll give you a severity grading for both superficial siderosis and for microhemorrhages. So it happened to be moderate for microhemorrhages and mild for superficial siderosis, according to this radiologic severity chart. This is another ARIA screening report from a different company. So let's talk about sort of the future of dementia imaging. ASI is actively working on a subcutaneous auto-injector for the lecanemab type molecule to bypass the need for bi-monthly infusion. So trials are in progress with that, and they aim to file for FDA approval in April 2024. And actually, another great benefit of that is not only the ease of use to be able to do it from home, but it will also cut down on the infusion reactions. Over 10% of patients will develop an infusion reaction, which sort of presents like flu-like symptoms, fever, flu-like symptoms following infusion. That tends to happen more at the beginning of treatment. So that will also help mitigate against that. In the future, we would like reimbursement for blood tests like the Quest AD Detect test. That's $400 out of pocket, and the Precivity AD, which is $1,250 out of pocket. And then we really need CMS coverage for that amyloid PET for beta amyloid confirmation to bypass the need for a lumbar puncture. Patients do not like having to get a lumbar puncture. So currently right now, one amyloid PET is covered per lifetime, but in a trial setting only. But again, as we spoke about earlier, on July 18th, 2023, CMS proposed to rescind the national coverage determination that is currently restricting amyloid PET coverage. So that then permits the individual Medicare administrative contractors, these MACs, to make coverage determinations. So right now, it's unclear when CMS will start reliably reimbursing for amyloid PET nationally and at what rate, but we're hoping that this is coming down the pipeline because CMS did make movement on this with this decision. Other things in the future will be new drugs on the horizon. We're expecting donanemab to apply for conventional approval, hopefully this fall, but if not, at least by this winter. And then we still need a cure. There's no cure, but prevention trials, as I mentioned before, are in progress. Okay, so let's look at some cases here, just dementia cases. There's several cases that we can review, but I'm going to limit it here just primarily to Alzheimer's and a couple of the other major dementia disorders. This is a 79-year-old with memory loss. They came in 2013 here, and you see some mild to moderate right temporal lobe atrophy. They had quantitative analysis done in 2013. When they returned 3 years later, their atrophy had significantly progressed and repeat quant was done. So here's a look at this quant study. In 2013, there was statistically significant hippocampal atrophy in the hippocampal atrophy and enlargement of the inferior lateral ventricles. That all progressed at the follow-up study. Now we have all these areas of statistical significance, and the HOC, the hippocampal occupancy score, which is a measure of mesiotemporal atrophy, was statistically significant. On the normative reference charts, you can see here how the hippocampal volumes are dropping rapidly off the normative curve, as well as the entorhinal cortical volumes and other measures here in the temporal, parietal, frontal, and occipital cortex. This is a triage brain atrophy report, which is again broken down into substructures and lobes of the brain. Anything in blue here is getting smaller, so the cortex is getting smaller. Anything in red is getting bigger, so the ventricles and the sulci are getting bigger over time. This is the type of thing that you would see sent to your PACS when you order quantitative MRI imaging. It's a very useful visual indicator here. This is another company's report here where, again, it's measuring the volumes of the pertinent substructures over time and comparing over time. So you can see things that have progressed in 2016. This is also from their report where it's pointing to areas of statistical significance. You can see in 2013 here, the hippocampi on segmentation and significantly smaller in size 3 years later. This patient also had on GRE multiple little microhemorrhages. So they had cerebral amyloid angiopathy. This was not a treatment patient. And then they went on to get an amyloid PET, which was positive diffuse binding throughout the cortex. So this patient had both Alzheimer's disease and cerebral amyloid angiopathy. This is an 86-year-old with memory loss and mild right temporal lobe atrophy. There was statistically significant mesiotemporal hypometabolism on, this is the PET CT images, and this is the PET MRI, which I fused to the FLAIR sequence here. And I run all these through the MIM neuroanalysis software. So again, it was statistically significant. Look at the dramatic progression in atrophy by 2016, at which time quantitative post-processing was done, and multiple areas of statistical significance on this quant study. And same with here on the other, this is another company's quant study here. And so this patient went on to have an amyloid PET, diffuse binding throughout the cortex, a positive amyloid PET. So this patient has Alzheimer's disease. Case 3 is a 73-year-old with memory loss, and we see here moderate right temporal lobe atrophy. We see some reduction in the volumes on quant imaging in 2016. So here's the reference charts here on one company. Here's another company, triage brain atrophy. This patient went on to have amyloid PET in 2015. This is the amyloid PET CT fusion and PET MR fusion, which I fused the T2 weighted images, and this was positive. So this patient has Alzheimer's disease. This patient is a 70-year-old here that had some atrophy, but not a lot. And if you look here on the FLAIR images, we see this cortical infarct here, another small cortical infarct here. This one's on the primary motor motor cortex, a few little lacunar infarcts in the cerebral white matter. This was their DWI in 2020. They came back in December, and now we have an acute infarct in the right cerebellar hemisphere. On the GRE, again, this is a non-treatment patient. We see superficial siderosis and other little microhemorrhages scattered around. On the FDG PET-CT in 2020, we see cortical hypometabolism diffusely in the parietal lobes and the temporal lobes, and particularly in areas where we have infarcts here in the brain. This is the FDG PET-CT cortical hypometabolism that was statistically significant in the temporal lobes and in the biparietal lobes. Here's the FDG PET-CT again with color fusion. We have all the temporal lobes are hypometabolic, as are the parietal lobes and the posterior cingulate gyrus. This is the FDG brain PET MR fusion, which I fused to the FLAIR, and again, statistical significance, temporal and parietal. That was a patient, obviously, that had Alzheimer's disease. Moving on to this next patient, this is a 73-year-old male with profound visual hallucinations, delusions, gait difficulties, resting tremor, frequent falls, and only minimal memory loss. On the MRI here, we see atrophy, moderate atrophy in the bilateral parietal lobes, as well as atrophy in the bilateral occipital lobes. When we look here on quantitative imaging, we have some atrophy here in the occipital cortex, as well as within the hippocampi. And amyloid PET was done. Here's the PET-CT, amyloid PET-MR, and this was positive, diffuse finding of the tracer throughout the cortex. So the patient went on to have a tau PET in 2019, and we do see some tau deposition here in the occipital lobe on the right, a little bit in the posterior cingulate gyrus, and a little in the temporal lobe. The patient then came back for an MRI in 2021, and we have some progression of atrophy in the parietal and occipital lobes. Here's an FDG brain PET-CT that was done in 2021, and we see statistically significant cortical hypometabolism in the bilateral parietal lobes, as well as within the bilateral occipital lobes and in the temporal lobes. And this is the FDG brain PET MR, again, where you see statistical significance in the occipital, parietal, posterior cingulate gyrus. And here's the fusion with the MRI as well. This is the FDG PET surface map in 2021, where again, we see parietal and occipital statistically significant cortical hypometabolism. So this actually was a patient with dementia with Lewy bodies. You get abnormal deposition of alpha-synuclein, where these Lewy bodies here in the cells. Now, you notice that this patient had a positive amyloid PET, which typically you would think of Alzheimer's disease. But as you probably remember when we went through one of the earlier slides, you can get beta amyloid deposition with DLB. And in this case, it was enough a deposition to turn the amyloid PET positive. It's much less common than Alzheimer's disease, 1 million in the US versus 6.7 million with Alzheimer's. Survival rate is typically 5 to 8 years after diagnosis. The important thing is 80% of them will present with visual hallucinations. So if you get a history of this, be thinking DLB. And so that's the presenting symptom in most cases. And then again, you can have that amyloid deposition and neurofibrillary tangles with DLB, but not as much as with Alzheimer's. This last case is a 74-year-old woman with personality change and memory loss. This is the patient's FDG brain PET-CT in 2018, and we see here statistically significant cortical hypometabolism in the bilateral temporal and bilateral frontal lobes. This is what it looks like when I run it through the MIM neuroanalysis software. Anything in red here is above the midline, and the blue is below, below the mean. And this is statistically significant if it's more than 2 standard deviations below the mean in the left and right hemisphere by z-score analysis. So we're statistically significant here in the temporal lobes and in the frontal lobes. And then this was a negative amyloid PET on this patient in 2017. This is what the CT looks like. You see the dramatic progression and atrophy in just 1 year. I mean, look at these temporal sulci compared to what they were a year ago. Look at the size of the temporal horn. That's really has progressed over time. And then in 2017 and 18, look at the frontal lobe sulci. Here's the superior frontal sulcus compared to what it was just 1 year earlier. So this was a frontotemporal dementia case. There are 3 main subtypes, the behavioral variant, the non-fluent, and semantic. This is the most common, this behavioral variant here, which manifests as personality and behavioral changes, which is what this patient had. 30% are hereditary, most notably the behavioral variant, which is an autosomal dominant type. And there are different genetic mutations that can occur with this. This tends to present in younger people between 45 and 60 years of age. It's much less common than Alzheimer's disease, 55K with frontotemporal dementia in the US, as opposed to the 6.7 million with Alzheimer's. But interestingly, it is the most common dementia in young people less than the age of 60. The survival rate is typically 6 to 8 years after diagnosis. They should have a negative amyloid PET. You should not get amyloid deposition with FTD. And other diseases that are part of the FTD spectrum can involve motor changes, such as ALS and cortical basilar degeneration and progressive supranuclear palsy. So in summary, the dynamic landscape of Alzheimer's disease will have a profound effect on both patients and on neurologists, as well as neuroradiologists and imaging enterprise. So we all really need to be geared up for this. Neuroradiologists are going to play a key role in clinical decision-making about the eligibility and continuance of disease-modifying therapy. So it's important that neuroradiologists are trained in how to read these ARIA cases. I can tell you at our imaging enterprise, we are doing I'll do an internal webinar, which all of our neuroradiologists will participate in the training, and they'll actually get a certificate if they complete. Both ASNR and RSNA are also actively thinking about issuing certificates after training programs as well. Now, imaging centers will need to have agility to adapt to the significantly increased scan volumes. And finally, just remembering that this is a really exciting and pivotal time in the history of neuroradiology. We feel like we're up for the challenge, and we're willing to play a key role in the struggle against this absolutely devastating disease. Thank you so much for joining us.
Thanks so much for your lecture, Dr. Bash. We can take some questions now if folks want to put those in the Q&A box. We've got a few already in here. Dr. Bash, how do we bill for QMRI?
Okay, so for quantitative MRI, traditionally people have billed under the old 3D code, but it really was not meant specifically for quantitative post-processing in the brain. And so a really exciting event happened on July 1st, 2023, just recently here, where the AMA granted specific CPT3 category codes for quantitative imaging of the brain. So that is wonderful. Those will go into effect on January 1st, 2024. So we strongly encourage everyone to transition from billing under the old 3D code to the dedicated QMRI codes. Now, these CPT3 codes are tracking codes, so there's going to be inconsistency in payment initially. But if everyone starts billing under these new codes, that will really drive a conversion to a category 1 code, which then will become reimbursable. So it's very important for people to be aware that the dedicated codes are out there and to bill under those starting January 1st.
Awesome. What are the biggest practical challenges awaiting us in therapeutic dementia imaging, and how do we overcome them?
Yeah, so I think one of the biggest challenges is going to be communication between the neuroradiologists and their referring neurologists. Because if the neuroradiologist doesn't know that the patient is on treatment, then they know to screen for ARIA, right? So they see blood products, they may think progression of cerebral amyloid angiopathy, they see edema, they don't know what is causing the edema. So one strategy that you could use that I suggest would be to have the referring neurologist have that conversation and maybe have them order their studies as AD therapeutic baseline. If it's for the patients on treatment, that will alert the neuroradiologist and scheduling that the patient is on treatment and they're doing their baseline MRI. And then AD therapeutic monitoring for when they come back to do their scheduled MRIs, or if it's an unscheduled after they are already on treatment. And then if it's a patient that has dementia, but they're either not in treatment category, they're not eligible for treatment, maybe they're more advanced Alzheimer's, you could just have them order it as a routine non-treatment dementia study. But if you have consistent language every time when you order the study, that's going to trigger the correct dementia protocol. So that communication is very important. And then also the backwards communication from the neuroradiologist to the neurologist if dosing must be suspended if the category of ARIA warrants such. And then the other thing is really planning. Consistent protocols should be in place already. So at our imaging enterprise, we'd like to do a dementia protocol on all of these patients. So again, the mandatory sequence, we're just going to do a routine brain, but we'd like to add the 3D T1 instead of the traditional T1, so that the patient is eligible if we want to do quantitative MRI. You need the 3D T1 to do quantitative MRI. So, every, protocol should include a GRE, a FLAIR, DWI, and a 3D T1 at a minimum. And then to accommodate be aware of and plan for the increase in MRI volumes. So, one thing that you can do to, mitigate the high volumes is things like deep learning for image reconstruction, this AI tool that will allow you to scan your patients 50 to 75% faster, but still actually have, in fact, better image quality than if you hadn't applied this AI solution. That's something we use throughout our imaging enterprise. And it's an extremely useful tool, which really is moving into standard of care at this point in time. The other thing is to plan for, staffing to cover increased volumes. And then the other component is training neuroradiologists. If neuroradiologists don't know what ARIA is, they don't know how to read ARIA cases, they cannot play that key role that is expected of them. So training is very important. So again, at our imaging enterprise, we're going to do an internal webinar that all of our neuroradiologists on the East and West Coast will attend, and they'll get a certificate. But ASNR is going to also offer training, and RSNA. And so training is very key, and a big educational initiative is needed there.
Great. Okay. What about the controversy surrounding or identifying amyloid as causing Alzheimer's disease?
Well, I think everyone's pretty much in agreement that amyloid and tau are both biomarkers for Alzheimer's disease. There's always, a bit of a question of the balance between causality and association, but we know that causality is at least at some part a component, because ApoE4 homozygote carriers have a 12 times increased risk of developing Alzheimer's disease, and they also have an increased risk of developing hemorrhages. And we know that ApoE4 is tied to impaired clearance of the beta amyloid plaque from the brain. So that is a sort of a causality component. And we also know that from the disease modifying trials, that when you effectively clear the beta amyloid plaque, which all of the monoclonal antibodies do, that there is a slowing in cognitive decline. So that is another argument for that. So I would say, I wouldn't worry about it so much, just worry about what the end result is. Is the patient getting better, over time? Or not getting better, but at least slowing the rate of progression.
All right, one more question, and this one's a little bit more specific. We utilize SWI in our routine MRI brain protocol. Just want to confirm that counts for ARIA-H must be done on a GRE.
Yes, so the ARIA grading scale was based on GRE, not on SWI. The trials purposely only use GRE because pretty much any scanner can do a GRE. Not all scanners have the capability to do SWI. Certainly the newer ones do. And then, also sometimes they, it's a longer sequence. And so the trials wanted to incorporate something that everyone could do consistently, which is GRE. Now, if the grading was done on the SWI, it would be probably a different grading scale, because SWI is more sensitive for bleeds. So again, it's not a problem if you're doing SWI. It's just if you can also then add the GRE for the grading of ARIA, so that everyone is consistent across the board, just because there is a higher sensitivity for blood products with SWI. And then the other component also is, sometimes SWI is harder to interpret. Not all neuroradiologists love it, just because sometimes it's hard to tell if something is an end-on vessel versus a microhemorrhage, whereas on GRE, it's much, you feel much more confident that it's always a microhemorrhage and not a vessel. So those are kind of the reasons behind that.
Awesome. Dr. Bash, thank you so much for your lecture today, and for everybody for participating in the question and answer session. You can access a recording of today's conference and all our previous Noon conferences by creating a free MRI Online account. Be sure to join us next week on Thursday, August 17th, for a lecture with Dr. Petra Lewis entitled Getting Promoted as Clinician Educator. You can register for this free lecture at mrionline.com. Follow us on social media for updates on future Noon conferences. Thanks again, Dr. Bash, and have a great day.
Thanks.